Hi, I am Jamie Munger. I am the strategy director at Smart Design. I am absolutely thrilled to be welcoming you all tonight to our 12th Smart Salon. Tonight's discussion is around the important topic of women's health and more specifically, bridging the knowledge gaps that exist in this space. And I am joined this evening by three experts on this topic and my wonderful co-host, Allison Fonder from the company Core77. I'm wondering, Allison, if you'd like to do a quick intro as well.
Sure. Hi, everyone. My name is Allison Fonder. I am a senior producer at Core77, which, if you're not familiar, we're a design editorial platform, and we have a blog. We have our Core77 Design Awards, as well as Coraflat, which is a job search engine for designers. But we're all here today because of our salon, which started from kind of a discussion that was going on at Core77 that merged with the expertise at Smart Design around the field of healthcare. And we wanted to kind of expand the conversation to talk about the realities in women's health and how there's just an inherent lack of knowledge and lack of technological advancement in that area over the past decades.
Excellent. So I thought that maybe next we could have our guests introduce themselves. So we have three of them with us today. Each of them spends a lot of time thinking about these issues in depth and are each doing really interesting and phenomenal things in their own right. So I thought maybe we could go through one by one and allow them to introduce themselves and maybe talk a little bit about a project that they're currently working on. We have a little bit of visual support to go with this. So maybe first of all, we can turn it over to Maria. If we can go forward one more slide, we can start with you if you'd like to do a quick intro.
Sure. Thanks, Jamie. And thanks to Core77 and Smart Design for putting on this salon. I'm really honored to be a part of it. My name is Maria Lally. I'm the Vice President of Design and Development for Seek Women's Health. We are a women-led company based in Portland, Oregon, that is focused on improving women's health experiences, specifically by creating better products for a better pelvic exam. So we've created a Nella line of products to address unmet needs in gynecological care. And I can just quickly go over what those products are. We have three products. The Nella New Spec was the Core77 winner in commercial equipment and the Community Choice Prize, which was exciting. People, I think, have been talking about this idea of a better pelvic exam for a while. And so kind of reflected that desire. But I don't know if anybody has seen a typical reusable speculum. I have one here. It is cold, sharp, jangly, scary, often described as a medieval torture device. So this is what we wanted to solve. If you can see me on camera, you can hear it if you can't see me. But so with our new spec, we really tried to improve all of those aspects. So, and there were many for both the patient and for the providers as well. So keeping it warm to the touch, much narrower, about the size of a tampon. So it's something that we know that would be comfortable for most women and people receiving gynecological care. And the way it does that is by kind of distributing the opening across 4 different elements instead of 2 larger bills. So that makes it more comfortable for patients. It still gives the visibility and access that providers need. And it's quiet, it doesn't induce anxiety, it just improves the experience for everybody involved. We also have a couple of other products that are accessories to the speculum, a sheath, the view sleeve, which can retract vaginal tissue, again, helping providers to access and visualize while also improving comfort for patients. And then the view light, which is a light that goes directly onto the speculum so that providers get the visibility that they need where they need it, typically looking at the cervix. So overall, our product line is really intended, like I said, to improve the pelvic exam for anybody receiving gynecological care. And that has been the bulk of my past 5 years, was going from from initial idea and research as part of Seek to commercializing these and putting these on the market.
Very, very cool. Thank you so much for that intro.
Thank you.
And thank you for your work on a personal level. I was wondering if Alyssa, maybe you'd like to go next and give an intro and tell us some things that you've been working on lately.
Sure. Thank you. I'm really honored to be here and excited to be a part of this conversation. My name is Alyssa Mesa. I am the design manager at Upstream USA. We're a nonprofit organization that works directly with health centers to remove barriers and expand access to contraception. And we do that through technical assistance and quality improvement work with health centers of all types, hospitals, big, large systems, small federally qualified health centers, and sort of everything in between. What you see here on the screen is a GIF of a project that we worked on with Smart Design to create our own suite of patient education material. We call this the birth control decision-making wheel. And what it is a tool that providers can use during counseling sessions with patients to better facilitate a conversation about birth control. It allows patients to easily compare methods based on their preferences and find what's right for them. And Maria, I'm so glad that you brought show and tell today, because so did I. I have the actual wheel here in front of me. If you can see this, you can see that the top layer spins and it reveals more information about that particular birth control method. There's some like filtering and organizational prints color-coded to sort methods. And then there's a reverse side that actually goes into bleeding changes that you might experience with that method. So yeah, really excited to be here and participate in this discussion.
Awesome. Thank you so much, Alyssa, for coming. And then last is Colleen. Would you like to do an intro and talk a little bit about your work as well?
Sure. Thank you, everyone. My name is Colleen Newland. I am super excited to be a part of this conversation. So thank you, Core77 and Smart Design, for enabling this conversation to take place today. I'm a strategic designer at Philips. Philips is a health tech company looking at the whole continuum of care. We're about 400 designers globally of all different kinds of disciplines. But for me, I'm an architect by background. I really like to work at the intersection of environments and technology and services coming together in healthcare specifically. I think we're seeing more and more of this work is beyond the walls, so to speak. So it's really virtual care and service design more and more. And the two projects that I have thrown up here are ones that are very near and dear to my heart. So one is a next generation NICU, or a neonatal intensive care unit there on the top. This was a vision concept project, like a decade in the making, with a lot of designers at Philips collaborating on it. It's essentially like an adaptive environment with advanced analytics and a lot of technology to help support babies born prematurely. But beyond that, like really looking at how technology can support new workflows and ultimately better experiences for, in this case, parents and infants and their clinicians. And an offshoot of that is a room we call the lactation lab beneath that. And it was kind of an offshoot of the NICU project, where we were like, wow, we spend a lot of attention on these really acute, expensive areas in health system, you know, in hospitals essentially. What about these more overlooked spaces like a lactation room or a milk expression room for moms, which is usually like a closet, or it doesn't exist at all. But we were just trying to see what insights could we uncover if a group of moms at Philips explored this. And so sort of lo-fi, high-tech ways we can innovate and find new ways to improve that experience. In this case, it was looking at ways to use technology to kind of balance social connection and privacy in the whole milk expression experience. So those are two projects very near and dear to my heart.
Yeah, those are great. Thank you so much for that overview. All right, so I'm just going to cover a little bit of housekeeping before we jump in earnest. So for all of you attending, there is a Q&A box at the bottom of your screen. You can post any questions that you have there. Allison is going to be keeping an eye on it, and there is a portion of the discussion later in which we'll refer to those questions and actually talk about a few of them with our expert panel. Excuse me, there's also a chat window for you to put comments, thoughts throughout the conversation. And if the panelists so desire, you can also post links into the chat if you want to share. Also, the session is being recorded and there will be like a written summary along with all of those links available in approximately a week. So check back the Smart Design website for that. All right, let's begin. I think we can move screen.
I'm going to get out of screen share mode and into
Yeah.
gallery view. Just
Perfect. Here we all are. So let's begin maybe on a slightly personal note. We're all women on the panel, and we've each sort of likely experienced some sort of ripple effect of the knowledge gap in women's health and healthcare, directly or indirectly. So I thought maybe we could just start by talking about what got each of us sort of like initially interested in the topic of women's health, and if there was a personal or professional experience or an origin story that sort of inspired or even provoked you to get involved in this space. So I was wondering, Colleen, maybe if we could start with you.
Sure. Well, I chose those two projects, the first two projects that I was talking about, the NICU area, the neonatal intensive care unit, has really become a passion of mine for very personal reasons. We were actually like building the, that what we call an experience lab. We were actually building that room like in our Cambridge studio. And I, at the time, gave birth prematurely, like totally unexpectedly. So it was this weird mashup of personal and professional worlds all of a sudden. I remember the nurses saying to me like, oh, I bet you never knew the NICU existed. And I was like, no, actually, like we're doing a whole study of this at work. And this is like, you know, hitting too close to home actually. And it was humbling, right? I thought I knew a lot about the NICU having studied it, but actually experiencing it was something totally different. And I came back to our lab and was really looking at that vision with a new perspective. My problems weren't what I expected them to be. Specifically, as you can tell, I dove into the lactation rabbit hole. I struggled a lot with the whole nutrition piece of like how to provide nutrition for my baby in the NICU for an extremely long period of time, and realized that a lot of parents struggled with this. It was a huge challenge, and we weren't really specifically addressing it in our vision, our like company vision for the NICU. And so we were just asking the question like, hey, can we explore this? We think this is really important. We think we can innovate around supporting moms better in the, you know, not just in the NICU, but in the workplace and beyond. And Phillips was really like, sure, yeah, go for it. Like if you see something, go for it. So I think it's just that, like experiencing something very personal, it just further fueled my passion for designing for these kind of overlooked areas, which turns out to be a lot of women's health, unfortunately. So
Yeah,
that's kind of my story.
Yeah, that's a great story. Thanks for sharing that. I don't know, Maria, would you like to go?
Sure. Yeah. Seek was started from a very personal place by our founder, Fatih Khosrow Shahi. She was going through years of IVF treatment, but was also working in healthcare consulting at the time, and just was really surprised by the lack of innovation within gynecology and all of the tools and spaces around it. So that became her main mission, was to start a company to innovate in that space. And she chose the speculum as kind of like the symbolic, you know, crux of that whole mission to redesign it. And so I was involved in the very early discovery and ideating on her initial idea. And then I went on maternity leave to have my first child. And when I was getting ready to come back to work, she offered me a job as the first employee for Seek, which was just in and of itself interesting because, you know, how many women get job offers when they're coming off maternity leave? Not a common thing. So to me, that was really symbolic as well of the mission of the company and of the type of work we were doing. So it was a really personal connection for me, and it was obvious that it was a good fit, and that I was really excited about that, all aspects of joining on. And so I have been working there since. So it's really connecting that desire to, my background is in industrial design as a consultant and working for all kinds of different clients, but healthcare was always a very interesting one to me, but I didn't spend a lot of deep time in it. But since joining Seek, I realized that it is the space that I enjoy the most, just because of the great need in the space.
Yeah, I know what you mean. Alyssa, would you like to go?
Yeah, thanks. So before I started working at Upstream, I was working on contraceptive access. I was working and volunteering as a labor doula. And birth work is a really beautiful thing that I love very much. You see people at their most tender, some of the most tender and vulnerable moments in their lives. But it can be really frustrating as well, because you get up close and personal with some of the inequities that we have in our healthcare system. And it's a really good lens into everything that we're talking about today. You really begin to see how the patient experience is not centered in those spaces in labor and delivery, and how people aren't always receiving evidence-based care. And this is reality for many patients, and especially for patients of color and with less resources. So I really see this from a holistic perspective. I want people to be able to have the agency, access, to be able to make an informed choice, either to not have a baby or to have a baby in a labor and a delivery experience that they want. So I'm kind of working on it from a continuum: have babies or don't have babies, but let's make sure that everybody has the resources to be able to make the choices that are right for them.
Yeah, I think that's important to address both of those sides of the spectrum for sure. So moving on to the next question. I think anyone who is familiar with this space, whether you're on the patient end or the practitioner, knows, like we're discussing, that there's a lot left to be desired when it comes to the needs and expectations within women's healthcare. So I'm curious to ask all of you, what are some unique problems within the women's healthcare space that are an urgent need of addressing? And, what are some issues you're hyper aware of within your own expertise that are ripe for the picking, so to speak? I know you just stopped talking, Melissa, but maybe you could start the discussion there.
Yeah, definitely. So in our area of contraceptive and reproductive health, what we see is that patients don't always have access to equitable care, let alone care that is evidence-based and patient-centered. In terms of contraception, that means that patients don't always have access to the full range of methods, and that can be for a number of different reasons. Perhaps they don't live in an area where there are health centers around them. Perhaps that health center isn't able to provide all methods because they don't have the trained providers, or they can't stock the methods up front because of the high cost. And so if you're a healthcare provider, if you overcome those barriers and you do have a health center in your area, and you do have a healthcare provider that is trained and can provide you those methods, you still might experience unnecessary visits or long wait times to getting your care. Like we see this with IUDs and implants, for example, because of their high cost upfront. Not all health centers are able to stock those methods, have them on the shelves for when patients want them, or they don't have the staff, the personnel to be able to counsel and prescribe and place those methods. And so that inequity there is, I think, at best inconvenient, right? That's not the most optimal patient experience to experience delays and wait times in your care. But at worst, it can have negative health outcomes. We have health center partners who have told us, they have a great desire to provide all methods of birth control to their patients, but because of these barriers that they are also facing, they've had to tell patients, put them on a waiting list or schedule an appointment for them weeks or months out. And that patient returns to the health center, presents at the health center, and they're pregnant. And that wasn't a pregnancy that patient was necessarily planning or seeking. So, we know that birth control, being able to plan your pregnancies, is really important for maternal and infant health, but it's obviously also important for people in terms of planning their lives, planning their education and career goals. And so it's extremely important.
And Maria, with Seek being focused on women's healthcare products, what do you think are the most urgent needs in that space?
Yeah, I think it's kind of connected to what Alyssa was saying in terms of inequities and differences amongst different populations of people of what they have access to. One thing that comes to mind is that women's health is not monolithic, that gynecology isn't monolithic. You know, women are different, people are in different life stages, people have different sexual orientations, even race can be a factor. Body size, there's a lot of different variables, and I feel like women's health has been neglected, and even beyond that, it's been neglected in thinking that all women are the same, with all people going for gynecological care are the same. So I think that's just something overall that needs to be addressed, is to really understand the nuances and the type of care that people might need because of those nuances. One thing that comes to mind specifically is related to people with higher body mass. There was a Kaiser study that came out that we've been thinking about a lot at Seek as it relates to our products, but it was a Kaiser study that reviewed the data from about 1 million cervical samples and saw that overweight and obese individuals had a decreased incidence of precancerous samples, but an increased risk of cervical cancer. So there was a disconnect there. And their conclusion in the study was that the tools and techniques were not adequate for overweight and obese patients. So that was such a huge glaring, like, wow, this is a perfect opportunity of where design could lead to a better outcome. If the tools were designed for the patients, if the techniques were designed for the patients, then they would be able to catch cervical cancer earlier. So that was just one specific thing that I can think of within our space, that it's a very clear just gap.
And Colleen, I know you have some, thoughts about the research and data perspective. What do you think in that field needs to be addressed?
Yeah, Maria, like the gaps, I think that's it exactly. I mean, that's why we're all here. I think we see very clearly that women are just essentially devalued in research. I like to point to the NIH's study of its own research applications. I think they did this a few years ago now, but they found that their lowest award rate for applications were for research applications using words that used words like ovary, fertility, and reproductive. Those are apparently like hot button words that don't get you research grants. So we need more research. From my perspective, in my area of focus, I do, there's a huge opportunity and an urgent need in the postpartum, or what we call like the after you give birth space. I just think culturally, there's a lot of focus on baby in our society. There's a saying that like mom is the wrapper, baby is the candy, and once baby is out, like we discard the mom. That's kind of a crude way to put it, but I think the stats are very clear. Like in the US, our maternal morbidity rates are the highest out of any other developed nation. If you're Black, it's 3 to 4 times worse. And most of those maternal deaths are occurring after birth. I think it's like 52% are happening in this very vulnerable time. We put all the healthcare dollars that we do put into pregnancy are sort of in that pregnancy piece, right? If you've experienced it, or you've had a friend experience it, it's all those appointments leading up till birth, and then there's like a single appointment after the fact, and you sort of fall off the cliff. And maybe Alyssa, you've seen this as well in the women that you've helped. I mean, if we're not having these appointments after birth, we're not collecting data, quite simply. So we maybe just don't have a good grip of what's even happening postpartum to women. Even at Philips, to be critical, right? Like our portfolio of products historically really focused on pregnancy, and we really focused on baby, like we sell baby bottles, and we acknowledge this as a company, this is a really big gap that we have to fill. It's unfortunate that in US, like the insurance model drives a lot of our experience, and we see that reflected back like pretty directly in these high maternal death rates, unfortunately.
Yeah, I think the more you learn about the space in terms of the statistics, the more maddening it is. And so maybe that's part of this discussion too, is kind of inciting that frustration so people want to do something about it. But speaking to that, you know, the inspiration for tonight's discussion was initiated by the fact that there is so much missing information. There's this huge lack of data and knowledge when it comes to women's health that we want to start to unpack as designers. So I'm curious for all of you what comes to mind when I bring up that idea of the knowledge data gap, and what are the problems and consequences associated with that gap. We talked a little bit the other night, and I wanted to start with Colleen. Like, are there any facts that have particularly shocked you when it comes to the idea of the knowledge data gap?
Yeah, I guess I'm just shocked by how much we don't know. I remember specifically asking my doctor after giving birth prematurely. I asked him a million different ways, like, what caused this? How could this have been prevented? And he answered me a million different ways, but ultimately it was like, we don't fully understand what causes preterm birth, let alone what triggers like normal full-term labor. And I remember just being like, well, somebody working on that? Like, that's a really basic thing. I was just really shocked by that. And the more you dig into it, it's like you realize that most of the research we have around pregnancy was done in the 1940s. And an OBGYN described it to me as, she said, we're in the dark ages with obstetrics. And so it's like, Maria, when you talk about your medieval, the medieval devices, it's like, yeah, these things kind of, go hand in glove. But I mean, even looking beyond pregnancy, endometriosis, a colleague was telling me the other day that takes on average of 8 years to get diagnosed. That's an extremely common, extremely painful condition. It needs to be diagnosed early. So there's maybe a combination of bias happening there, where maybe women aren't believed in their pain levels, or we just don't have good tests for it yet. But I mean, all these things compound, right? Like the lack of data means we don't have the technological advancements. There's the bias and stigma. Some of these things we just up until recently don't feel comfortable talking about out loud. They were sort of like, keep it under the table kind of thing. But ultimately that just leads to what we've been talking about: delayed care, or you're undertreated, or you're improperly treated, which is the worst.
That kind of ties into a question I had for Alyssa of, you know, how have research studies kind of contribute to this gap as well? I know you have a few references to that.
Yeah, you know, to continue on the thread that Colleen was speaking on, you know, where there's a big lack of research, right? Women aren't always included in these large clinical trials because it's too complicated to include women, whatever. But even when there is research, sometimes there's this big gap between what we're discovering in research, the latest evidence, and then what becomes standard practice, standard care. I think of this really from like a doula perspective. And this like sort of this phenomenon is like well discussed, like the evidence practice gap. And basically just, it means that it can take a long time for those evidence to become standard care. And so in labor and delivery, you see this a lot, very common interventions like continuous electronic fetal monitoring, continuous IV, not eating during labor. When you start to investigate why those like policies and ideas are in place, you, like to Colleen's point, find that their origins are in research done in the 1940s and 1950s. I think one sort of really illustrative example of this is something called the Friedman's curve, which was a study done in 1955 with 500 white women tracking how long it took for those first-time mothers to give birth. In that study, it was observed to be 14 hours. And for a very long time, that was how providers measured how long birth should take. And if birth wasn't taking, if you weren't on that schedule, then you might be introduced to some interventions, perhaps C-section. And the United States has historically had a very high C-section rate. And then in the 2000s or something, researchers began to reinvestigate this model. And what they found was that, oh, actually, for modern women, birth is not taking 14 hours, it's taking longer than this, and it doesn't track to this original Friedman's curve. And so then from there, eventually, like in the aughts, this model then was considered obsolete. And now professional bodies like ACOG don't recommend its use. But I think it's a pretty illustrative example of the harm that can actually come from using these outdated models, using this outdated research, because it really has practical effects on patients experiencing unnecessary interventions and unnecessary procedures based on outdated data.
Yes, just seething over here about all this. Maria, what are some frustrating elements of the gynecological process that aren't getting researched and addressed quickly enough, you think?
Yeah, I think the 7 to 8 year gap that Colleen mentioned for endometriosis was one of the things that came to mind, and it connects to also the idea and the problems with bias around pain in women's health. For the example of endometriosis, it's pain being dismissed as normal, or just all in your head. That's just kind of a classic problem there has been in women's health. But then on the other hand, I think there's a dismissal of the psychological aspects of pain and how what negative impact that can have on your health. So anxiety around gynecological exams and delaying care, which then leads to increased incidence of cancer. So I think there's a lot of nuance and misunderstanding around the psychology of pain and anxiety related to women's health. Another thing that came to mind was the kind of IUD insertion. There isn't really clear protocols around pain management. And one provider that I was reading their take on it, their perspective was that it was because IUDs were traditionally given to women who've already had children as birth control, not women who hadn't. So it's not as painful for insertion if you've already had a vaginal birth. If you've never had a vaginal birth, then it becomes much more painful, which to me was just like nobody thought to think about that and maybe think about, some protocols that would take that into account. So it again points to the lack of research and a lack of kind of holistic and nuanced study of the issues at hand.
Yeah. All right, so we spent a little bit of time talking about what's missing and the knock-on effects of that. So I kind of want to switch lenses a little bit and talk about the role of design in bridging the gap. Everyone on this call has some sort of background in design. Likely many people who are watching or listening touch design in one way or another as well. So yeah, I'm wondering, what is our role in the design field in being these sort of potential knowledge gap closers. We go seeking insights often to ground our design work on. So I'm wondering if we can discuss a little bit about where we think designers should be conducting research and who they should be speaking to in order, to gather the right kind of insights to bridge the gap. So I thought maybe first I'd ask Alyssa if you wanted to talk a little bit about your point of view for design and closing the knowledge gap, and maybe specifically some of the work that you've done at Upstream.
Yeah, I think that we need to be talking to patients more, just like quite honestly. To speak a little bit about a project that we worked on with Smart Design, we wanted to create these birth control materials that you all saw earlier in the presentation, because we wanted to help patients have better conversations about birth control with their providers. And what we learned was that birth control was a really complicated topic for people and really nuanced. And preventing pregnancy was something that was top of mind for them, but so were other considerations, like what were the potential benefits and what were the potential side effects of choosing that specific method of contraception. We, how will this affect my period? Can this help me with my acne? How will this affect my fertility? All of these other questions were things that people were asking themselves about birth control. That was really important for us to learn, because then we designed our materials to help facilitate those conversations and help people explore those questions with their providers. We learned things, like people were really interested in whether or not the method they were looking at had hormones or not. And that was something that I don't think we would have learned like a couple of years ago even. So it was really important for us to get that research and to be talking to patients to learn more about their needs around birth control.
Yeah. I don't know, Maria, do you have anything to add to the conversation of the role of design and some of the more effective methods that have worked for you?
Sure. I mean, I definitely echo that. Talk to patients and talk to patients more. I think that's always. I mean, that could be an endless process, which does make it challenging, knowing all the nuance that exists in the realm of gynecological health. Like being able to, you're not going to be able to address everybody all at once with a one-size-fits-all solution. You're going to need to really study the different areas to make sure you're delivering on what the needs actually are, and that can be challenging for especially for smaller companies. But it's definitely a worthy goal that we should be working towards. But also making sure that you're designing the right thing for the right reasons, and really getting the background, and then understand the context in which it will be used. So you can design the best product, but if providers aren't interested in using it and taking it up and incorporating it into their practice along with kind of a more holistic way of interacting with patients, then it might be dead on arrival. So you really need to think about a holistic system and how to set it all up for success, and to find the right partners that will kind of champion and share the same mindset.
Absolutely. So as we were discussing, there are a vast amount of problems yet to be addressed within the women's healthcare space. And I think, like we said the other night, like because the bar is set so low, sometimes that means that a really helpful solution can actually be an incredibly simple one. I'm curious if you all have more thoughts about, perhaps more overlooked needs within the women's healthcare space that aren't necessarily tied to a medical product where designers can intervene. Alyssa, you were kind of talking about that the other night in terms of exam rooms and whatnot. I'm curious if you have thoughts on that.
Yeah, I think when we were speaking about it earlier, I had very recently just was shared with something that a coworker had sent me, like from Twitter, about a OBGYN who had asked their patients, I'm redesigning my exam room. What would you have me do in this redesigned exam room? And the patients came back with some pretty simple, but I think powerful things. One of them was readjusting the exam room, the exam bed, so that it wasn't directly facing the door. So if the door was open, that passerbys couldn't see the patient in a state of undress. Like a hook for hanging up their clothes when they got changed to be in the dressing gown. Very simple things that for me as a patient rang very true for my own experiences being in those spaces. And this is from Twitter, so take it with a grain of salt. I don't really know anything about what happened with this, but I think it's a pretty illustrative example of that these don't have to be incredibly complicated solutions. There are sort of like simple service and like spatial design changes that we can make to improve the patient experience. And I think that piece about like patient experience, it's so often left out of the discussion. Like, how will somebody experience this, like in labor and delivery? How is the person going to experience this intervention? How are they going to experience this medical procedure? And I think it's so often thought about as like discrete from outcomes. We're very outcomes focused, and our outcomes are not that great, as Colleen pointed out. But there's such a connection between experience and outcomes. When patients' experiences are better, that's associated with better outcomes. So when we can work to be improving that patient experience, we're improving healthcare overall. And sometimes these solutions don't have to be complicated or expensive.
I realize too that, Colleen, you have some experience in this field too, if you have any insights from your work.
Yeah, I love what you just said. Yeah, and then like, how do we measure experience, Alyssa? Like there is a direct connection there. I don't think it's valued enough between experience and outcomes. Yeah, I think sometimes the simple interventions can be best. Like the two things that pop into my head are, one of them is just pretty simple in the sense that like artwork. This came up in some of our studies in the NICU, where it was really unsettling for families going into the NICU to be confronted with all the images of happy, healthy, chubby babies that are in like the labor and delivery ward. So it's just a simple suggestion to the hospital, like maybe expose some other experiences. Let's show some skinny babies and some sick babies and some disabled babies on all these images that you have on the wall. But even like simpler than that, I think with our lactation lab project, it came down to Post-its and figuring out that was a really interesting way just to expose the need for social support. So in the lactation room in our office, another designer just put a stack of Post-its in there, and she just started sketching out like her miserable day for that particular day. And within a matter of weeks, all these women that use that room sort of asynchronously, like never together, you're in this very isolated experience where you feel alone, you're pumping milk at work, you feel like questioning all your decisions. And in a matter of weeks, we felt like, wow, everybody, like we're all going through the same thing. There's hilarious sketches on the wall, high points, low points. I think just part of that was just like acknowledging the tedium of it and bringing levity to a situation where like you at least realize, well, these are shared experiences at very least. I think it hit home for me when another woman from a different office across the country came and used the room, and she said, oh my God, this room like just totally changed how I think about this experience. Like you just made my day, just reading all that I know that I'm not alone, essentially. So yeah, it could be as simple as a Post-it note sometimes left in an exam room or a pumping room.
Post-it notes, they're not just for designers.
Right.
Another kind of aspect of this is, there are methods beyond the physical and spatial that can also improve a person's relationship to their health, and, such as interactive products or services. So I'm curious with all of you, what is the role of service design in women's healthcare, and what role can that play? Maybe Colleen, again, you could pick this up. Like, what are you seeing at Philips going on? How is your team thinking about this space?
Yeah, so it's big, right? I mean, you almost can't think about healthcare without taking a service design approach. It's not just a single appointment or a single exam. You, as a designer, you really have to uncover all these hidden moments that make up healthcare. I think we think of it sort of as like in two parts to really simplify it, like the journey to care. So like driving access, engagement, awareness, and then the journey through care, which is a lot longer, right? Like understanding how to navigate, understanding patient preferences, how do you build and break trust, understanding where you even are in the journey. One of the use cases we're looking at now is like increasing access to perinatal care for women so that means like basically ultrasound for women in low and middle income countries. Ultrasound is really the cornerstone of women and babies' health during pregnancy. And so taking a service design approach to that, I mean, if we didn't, we'd just say, oh, we're a device company. They just need the equipment and maybe a more portable form factor, and then off they go, problem solved. But we have to think broader, right? Like who's going to use these tools in these countries? Ultrasound's typically done by very expert techs. So we have to think about the technologies to guide virtual to guide people virtually so that non-experts can conduct these exams. And then you say, okay, well, you've got new technology, you've got new people using it, you're starting to give shape to a new process, which is giving shape to a new service. And then it's like, well, how do you make that service sustainable? Who's paying for it? How is it paid for? How are people going to see value in this long term? How will people learn about it? You know, like, how are we going to team up with local NGOs or whatever so that this is even accessible? So no company is going to solve these big service design challenges in healthcare alone. It's a partnership. We have to team up to think about it. It's just like the service design approach, I think, is just looking at all those different variables and how they come together to create that successful healthcare experience. So it's kind of a high level answer, but that's our current approach right now.
Yeah, absolutely. Well, going to a specific use case, you know, Alyssa, I know that your work at Upstream is very service focused. You come from a very service focused perspective. So why is that space so important to you and your work?
Yeah, it's extremely important. A core part of what we do really is focus on redesigning how contraceptive services are offered and centering and making sure that they're more patient-centered. So a core part of our quality improvement work is working with health centers to help them redesign and reimagine their workflows in order to accommodate a conversation about birth control, and then also the ability to offer them their desired birth control method in that same visit if the patient wants it. We also train healthcare teams to be able to have those conversations with patients, to ask patients of reproductive age, do you want to get pregnant in the next year? If the answer is yes, yay, amazing, let's get you to preconception counseling. If the answer is no, then okay, let's see if that patient wants to have a discussion about birth control. A partner of ours in Delaware, an OBGYN in Delaware, shared this story with us about how when she asked a patient her patient about her pregnancy intention and had a conversation with her about birth control and her goals, the patient responded, no one's ever asked me that question before. No one's ever taken the time to ask about what I want or what I need. And that was a pretty profound moment, like for the patient and for our provider. And I think that speaks to how something like a relatively simple sort of service intervention around making time. It's not so simple in practice, but like the idea is simple enough, of making time to have those conversations and to ask this question, do you want to get pregnant? This led to a sort of pretty profound healthcare experience between that patient and the provider. Yeah, I think it goes back to what we were originally talking about as well, how some of these relatively straightforward service interventions can have a big impact on patient experience and outcome.
Yeah. Maybe like sticking on this thread of like the smaller things that you can do to tackle what can feel sort of like an insurmountable issue. I think it's like a proper systemic problem, a lack of data around women's health. And I think it can often lead people to think that it requires policy change, and it does, or like big government investment, which it does. I'm not saying that it doesn't, but there are other things that can be done in tandem with that. And change can be very bottom up or very grassroots as well. So I thought it might be interesting just to hear from you all the sort of like smaller players that are inspiring you, maybe more fringe or more guerrilla or more informal people, organizations that you feel are just doing interesting things in this space from a technology perspective, from an insight gathering perspective, you name it. And I'm wondering, Colleen, if you'd want to go first.
Yeah, two things come to mind for me. Well, I'm on the topic of preterm birth. I'm super inspired by this. There's a team at Columbia Medical Center that is basically teaming up mechanical engineers with obstetricians to do research on the biomechanics of pregnancy. So like, how does the cervix open and what keeps it shut underneath all those forces? So it's a totally different mindset. You wouldn't normally see those two types of people interacting. But I think it's the way that we are going to get some solutions or some answers to these questions is to get different types of people thinking about the problem differently, like car mechanics on this topic. So maybe not a small one, but the other one that pops into my head is just moving some of the where we intervene as designers more upstream. And we talked about this a little bit last week about how human-centered design could be better taught essentially in medical schools. I do know that Dell Medical School down at like UT is doing this. They've actually have a program where their med students can be exposed to human-centered design courses. But imagine if like you could start to work with med students to talk about reframing issues from the patient perspective, understanding patient experiences from a different lens, rapid prototyping, co-creation with your patients, all those kinds of things I think could be really interesting to start to affect care like way earlier on, because a lot of times these habits are already highly formed. We're not putting all the blame on clinicians or providers by any means, but I think they can also be huge instigators. If they had some of these design skill sets, they could roll those out also into the medical field.
Yeah. Maria, has there been anyone sort of inspiring you from the edges lately?
Yeah, I think I am inspired by a lot of people starting companies that are just taking off, you know, kind of some of those very specific chunks of problems and really dealing with those. So there's a couple organizations in Portland, based in Portland, that I can think of. One of them is, their name is Medora, and they are developing and I think now going through clinical testing of an ultrasound device that's for postmenopausal women to help with vaginal atrophy. And it's just looking at new technologies and how they can address problems that have been dismissed, overlooked, just not considered. I think postmenopausal women in general, I think is an interesting group because people don't talk about menopause very much. I feel like we're just starting to talk about that more as another one of the kind of previously taboo areas that are becoming more acceptable to discuss and to talk about the specific nuances of medical and healthcare treatment. Another group is dealing with a postpartum hemorrhage and kind of applying a wound care device that they've developed for that specific use. So that's another really interesting thing. Just taking these like very discrete problems and trying to solve for those, and you know, hopefully more and more people and organizations are doing that, so that, you know, it can come from small organizations and for big, you know, large companies, multinationals or NGOs, like just having these things addressed from different angles, but having that kind of openness of design and of technology these days, where anybody can at least start to think about these problems and attempt a solution, and then they can just come to market faster.
Before we get to our final question, we wanted to address some of the Q&A going on right now, and I really want to thank everyone who has contributed that so far. One of the first questions that come up, there are quite a few questions around the idea of gender, and I'm really thankful for everyone who's brought up that topic because it's something that we thought about initially. And I'm going to mix them together, but Sarah Marie Gustafson is asking, what knowledge gaps have you identified in healthcare for trans or intersex women? And what are some of the ways design can consider alternate gender identity experiences for patients? And then to add to that, another person asked, any thoughts on how to advocate for those solutions? I can kind of throw that to anyone if you want to answer.
I can start us off. I think it's an incredibly important issue, and I'm thankful for the person who asked that question. I can't speak a lot to maybe like the medical knowledge gap, but I think that it's very clear in the sort of service provider realm how this is a gap. The kind of language that providers are trained and are commonly using when they're talking to patients. You know, women's healthcare while neglected and not integrated, is also then very hyper like feminized in the language and the space. And so I think it's really sort of building up this awareness issue of people who might be seeking reproductive health care, people who will become pregnant, people who use birth control, don't all identify as women. And so we need to be mindful of the language and how we're approaching people to make sure that we're really like reflecting their experience and meeting them where they are in terms of their needs. With our birth control materials, for example, and in the services that and in the way that we train our providers, we don't use gender specific language wherever possible. We use patients, and we train providers to be asking those gender identity questions and to provide gender affirming care. So my sort of long-winded answer is I think that there's this gap in training. I don't think that that's something that's like routinely given to providers in their training when they're learning how to interact with patients, and it needs to become more common.
I just echo that, Alyssa. Yeah, I mean, the things that I've come across on this topic have come back to training, and staff have told us they don't know, like they don't even have the vocabulary almost in some instances to know how to speak to patients. Even in really basic ways. We saw this in some of our NICU research of when you have two parents of the same gender, it's like, who do you call mom? And there was a lot of confusion from the nursing staff on that aspect of it. So they're begging for training. And I think, again, this gets back to my earlier comment about bringing these topics into the medical school curriculum to begin with, so that we're addressing this way more upstream. I think it's going to be critical. It's a huge gap.
Definitely. And I think, we've seen a lot of positive signs towards that in terms of clinics changing language, changing intake forms to allow for people to be able to give the information in a way that really reflects their current situation. And then from the perspective of devices and experiences, a lot of that we are really working with providers who understand their patient populations, who are really advocates for specific patient populations, to kind of give us that feedback. It's difficult with a medical device. You can't just go testing it on everybody. You need to have IRB approved clinical trials. And then from there, once we've made it to market, then it's released to anybody. And so from there, we really rely on empathetic providers, people who really understand the patient populations they're working with, and kind of becoming experts in their realm to give us feedback. And for Seek in general, we've had really great feedback that there are a lot of nuances and differences, but when it comes to gynecological care, there are a lot of fundamental problems with the tools that can be solved broadly. So that's kind of a positive of our devices kind of solving some of those problems that are just, really important baseline ones to get to improve.
There are several good questions, but I think this one also speaks to something we talked about the other night. Hugh P. Jedwell asked, what are the most promising opportunities that leverage new digital technologies to create better solutions in women's health? Like, where can technology be applied in a really effective way, you think?
I hate to keep harping on the ultrasound thing, but it's an area we're doing a lot of research on at Philips. It's just making this more accessible. So I think at Philips, we traditionally would design devices for the system, like for the hospitals, essentially, right? It's big machine, it's meant to be procured, it's plugged in a certain way, certain staff use it. It's great for the doctor, so to speak, but not great for the woman. And I think we're seeing this big shift of women saying, no, you come to me, figure out the technology so that you can come to me. There's sort of almost like a power shift going on. And so we're really looking at how we can adapt technology to be in places like in the home. It might not have all the bells and whistles, but I think that's kind of the interesting role that design plays, right? Is to help prioritize the need, like what are things that we can leave behind, where we've maybe even over-engineered, and where do we need to make compromises, or should we make compromises to ultimately get a better experience and outcome for women.
All right. Should I ask another question or should we go to the last piece?
Maybe one more question. They're so good.
Sure. I have another question that I found interesting. How might design researchers effectively engage with women patients in the healthcare space that are from a different cultural or linguistic background than our own experience or background, if you're from a different culture or background? Might be a difficult one to ask.
I can start. It's something that we have that we experience in the work that we're doing at Upstream. The birth control materials that I have talked about a couple times, we had translated into Spanish, and we engaged Spanish-speaking people to review those materials and make sure that they were understandable and culturally appropriate. And that's not exactly design research, but doing that step is not necessarily common when patient materials are translated into new languages. And I think it speaks to the need to center the patient experience and take into account people's differing perspectives and how they're coming to healthcare. Healthcare is not seen as this like universally benevolent or positive force in people's lives, right? Like people have had a lot of very traumatic experiences with healthcare, experiencing bias and coercion in the healthcare system. We see that with contraception. We've seen that in lots of different areas of women's health. So design researchers doing their own research to understand those like historical legacies that communities might have within the healthcare space, and then engaging people from those communities more directly. I think not just I'm the design researcher and I'm asking you, like partnering more with communities so that way, it's a more of a communal like learning experience where people from the community get to be in the driver's seat and in the lead. I think that would be a good place to start.
Yeah, I could not agree more. I think that's huge. Okay, great. So we've got one more piece that we want to add to this. Jamie is gonna
sure
introduce that.
So before we wrap up, let's talk about the future and where, we might be headed in terms of advancements. And let's think like 5-10 years in the future. I know in product development, you're often thinking 2-3 years in the future, but let's think like farther out. And, based on your experience and your insights and hunches and research that you've done, how do you think the space will be different in that time? And Maria, I wonder if you wanted to kick us off, maybe to talk about like some of the hurdles that in order to arrive at a future that we want to be in, what are some of the hurdles that we have to get past?
Sure. I think there's still just really huge hurdles in gynecological care, specifically about anxiety about exam period, and that leads to lack of compliance, which leads to increased cervical cancer in certain populations. And especially with the pandemic, that was a whole nother layer in the past couple of years, and currently that where care was paused, and then research saw kind of an uptick in certain cancer rates in different nations across the world. So it's something that it can't be, we have to figure out ways of not putting women's health and gynecological health aside and prioritizing it and making sure that people aren't falling through the cracks, whether that be because the tools aren't right for their type of body, or because they're afraid to get care because of their gender identity, or because they're afraid of the pain because of past negative experiences or sexual abuse. There's a lot of different facets that keep people from getting the care that they need. So I think really trying to address those things, and that means listening to patients and listening to what people are asking for, like that tweet that Alyssa had mentioned earlier. Like, there's like thousands of responses to that question when that doctor put that out there, because there's so much desire for a better experience. So really just, companies, organizations, healthcare systems, like acting on those things. I think that's just kind of essential in order for there to be improvement. And then beyond that, I think when we look at more at-home technologies and more technological advancement, understanding how to keep things accurate. There's going to be a big, I think, learning curve to that. Like, for example, if you think about it, at-home cervical sample, that's not going to be an easy thing. So we'll have to see how, what the accuracy is. It's kind of the question with COVID tests today, like how accurate are those at home versus at a clinic? So I think we'll see those same sort of questions with these type of sampling devices that will become probably more mainstream. And so there, it may not all be at the home. There might be a balance. So there's just some questions there that I think we'll really just need to make sure that people are keeping up with the proper healthcare routines to make sure that they're staying healthy.
Yeah, even being able to do it at home cervical test to me sounds quite futuristic. I know, like, the future is right around the corner in some ways. I don't know, Colleen, do you want to tell us what you're thinking about when you think about the future of this space?
Yeah, I mean, we already see that women, well, for better or for worse, right, go to apps before they go to their doctor. I think we've just become a lot more comfortable with some of these tools, and virtual care, of course, being really elevated by COVID. I totally agree, Maria. Like, we talk a lot about moving care to home and having more self-enabled care at home. There's a whole load of service design that has to be thought through for that to actually work, and like you say, for that to be accurate and meaningful data, essentially, that you can collect at home. But I think it's interesting how I think we've had this big shift, and people have much stronger opinions about what they want their health experiences to be. There's sort of this consumerization of health, and I think that's to the benefit of healthcare. When people start asking for and feel empowered to ask for these things and wanting and demanding different experiences, like the OBGYN's office, like that's when I think we'll start to see some change. And yeah, I think as things do sort of move into the home, or even to like CVS, like places just closer to, or maybe less institutional than the actual hospital, it will start to feel women's health. This area will start to feel less niche and maybe a little bit more commonplace and a little bit more exposed to the world.
Mm-hmm. Alyssa, do you want to round us out here? What is the future of birth control going to look like?
Wonderful future of birth control. I'll echo what Maria and Colleen said. I feel this migration to putting the power into the hands of the patient and less siloed and concentrated at a hospital or with the provider. There are some things that we're even seeing, like right now, not 5 years in the future, that are doing this. Like during the pandemic, some health centers were prescribing at-home birth control shots, something that is typically done at your care provider every 3 months. This was something that people were doing at home to reduce in-person visits. At-home IUD removal, I can see that as being something potential, and I'm excited about the work that the Marias and Colleens of the world are doing to improve the patient experience for people. I'm excited to see potentially new methods of birth control that really expand the options and meet people's needs better, because we know that we're not all satisfied with what we have currently. And I think that you're going to be seeing more investment in that space to provide more alternatives.
You're here. All right, well, that's the end of the discussion today. I want to thank the three of you so much for your time. If anyone who's been listening and watching wants to revisit the discussion or share it with other people, the recording will be posted on the Smart Design website, and there will also be a written summary published alongside it in about a week's time. Our next Smart Salon is January 25th, and the topic will be announced shortly. If you want to get updates or sort of early access benefits, you can go to go.smartdesignworldwide.com/VSS13. It's also posted in the chat. Allison, would you like to say a couple of words before we close for the evening?
Absolutely. Well, first of all, I want to commend everyone for being involved and for the work that you're doing. So essential. I'm really excited to see what's next. But I also wanted to kind of do a shout out about the Core77 Design Awards, because we want to celebrate all this amazing work and encourage anyone in the audience to submit. It's opening on January 6th. So I'm going to, share a link to our website if you want to learn more about it. But yeah, we want to celebrate this amazing work. So that's all I have to say. Thanks, everyone.
Maria, Colleen, and Alyssa, thank you so very much. Good night, everyone.
Thank you.
Good night.